is it then incumbent on the government now to fix this?
It is reformation of the public healthcare which is actually more essential.
The elephant is too big. There's no more room. Okay? Where is the elephant? Who is the elephant?
Hello, everyone, and welcome back to another episode of Beyond the Headlines, your one stop for all the top stories that made the week's headlines and more. I'm Hazween Hassan. In today's episode, we continue to discuss the hotly debated hikes in medical insurance premiums. Last month, it was reported that medical insurance premiums are expected to rise between 40 to 70% next year, following notices sent by insurance providers to policyholders. This has been attributed to the rising cost of medical care in private hospitals as the primary reason. This week, after lawmakers deliberated the issue in Parliament, Prime Minister Datuk Sri Anwar Ibrahim said that Bank Negara Malaysia, the Treasury Department and the Health Ministry are reviewing the increase. He told Parliament that strict guidance and guidelines would be issued for medical and health insurance and tackle insurance and operators to take into consideration. This was then followed with 6 recommendations by the Parliamentary Special Select Committee on Health for the government to address the problem. Committee Chairman Suhaizan Kayat says this includes suggestions to introduce co-payment options, a mechanism to control prices of health services, and expedite the implementation of diagnosis-related groups, or DRG for short. Following the announcement, the Association of Private Hospitals Malaysia, or APHM, says it supports the cost control proposals. President Datuk Dr Kuljit Singh says the association enthusiastically endorses and supports the cost containment proposals. Now, Beyond the Headlines had the pleasure of speaking to Datuk Dr Kuljit in an earlier video call interview where he explained APHM's stance on the matter further and gave more insight. We'll hear more from Datuk Dr Kuljit in just a bit, right after I introduce my studio guest here with me. I'm joined by former Federation of Private Medical Practitioners Association Malaysia, or FPMPAM President, Dr. Steven Chow. Dr. Steven, welcome to Beyond Headlines.
Thank you, Hazween. A pleasure to be here.
Pleasure to have you here on the show with me.
Yes, thank you.
All right. Okay, so before I get to you, let's first hear what Datuk Dr. Kuljit had to say earlier. Now, I want to start off with this first. Earlier this week, and as you briefly mentioned earlier, you've been talking about this issue the past week or so, right? And in that, you have announced that APHM supports and endorses cost control proposals for private healthcare introduced by the Prime Minister in Parliament. So I want to know now, how does APHM now moving forwards plan to work with the government to implement these proposals effectively?
Thank you. APHM has always been advocating in controlling cost. But the narrative sometimes doesn't go in a correct way to the public when they look at the bill size and they look at the profits that the private hospitals make. And that sometimes misguides and gives them a wrong impression that private hospitals are profiteering. Private hospitals make about a 10% profit after tax. And out of the 10%, 80% of it will go into reinvestments. And then, of course, there are people who say that every business will reinvest, but they fail to understand that in the healthcare, the reinvestment model is not the same when you compare to the other businesses, because the trajectory of technology that you have in healthcare and we're dealing with patients' lives is totally different. We certainly have to be in robotics, in artificial intelligence, innovative medication, and the list goes on. And all this actually will be very expensive. And it is very much unpredictable when our currency to the US is normally not that stable. So these are the areas where parliamentarians, men in the street, sometimes will not understand until and unless you are in this business. And this business is actually very different, and it can be potentially quite difficult. Now, the government has suggested DRG, and repeatedly they have used the word DRG. In concept, DRG is a good system because it kind of values each procedure that you do with a price, so that patients would know, and also the payers would know exactly how much a particular procedure would cost. But we must understand that all the DRG models that have been used in the world are basically in public healthcare system or public fundings that have been used in a private setting. There has not been any solely private healthcare in the world that has a success story using DRGs, because the dynamics are actually very different when you use DRGs in a solely private setting. And I can give you an example, because every patient that comes to an hospital with a particular conditions will have their variabilities. And that variabilities are the ones that cannot be predicted as far as cost is concerned. If you do a total knee replacement, if you are a straightforward healthy patient, the cost will be a certain amount. But if you have other complications, probably previous infection, diabetic, other comorbids, the cost can actually escalate to a level that you may not be able to predict. So when you're going to use a DRG system and you're going to fix costs, very often in a private setting, you will realize that you will actually shoot above what it has been promised. And that is not very good, because once you promise a patient using a DRG and then you go back to the patient and say that there is going to be an extra cost, and this is not going to be a sustainable way. Maybe 1, 2 cases it can be absorbed, but if you're going to go long term in this model, then it's not going to be sustainable. Doctors and hospitals will tend to pick what they would want to do to be safe, and that is not what we want.
Okay.
And then these patients will eventually go elsewhere for treatment. So my final note on this thing has to be seen into the depths. A lot of discussion needs to be done. The private sector needs to be there to make them understand how private healthcare cost actually works out. Because if you're in public sector, you will not know this.
Right. Okay. That's good to know. Now, for perhaps for the benefit of our viewers, DRG stands for diagnosis related groups, right?
Yes.
Okay. Now I want to move on to. I'm sure you've heard now that there is a special select committee that the Parliament has formed. What do you think about the 6 recommendations?
I think the 6 recommendations are good.
Okay.
And I think it has got everything that you need to understand what it takes into the process of running a healthcare. But having said that, APHM is actually looking at detailed consultative sessions with Bank Negara, Ministry of Health, and even we don't mind members of Parliament to sit with us so that we are very transparent in our cost. We can tell you exactly what entails in a medical bill and how we have come to that particular figure. It's very transparent. We have done studies by reputable companies, independent reputable companies, who have dissected our healthcare, our medical bills, and you will be able to see how that particular amount is achieved. So I think that narrative is actually very important. And one thing that we sometimes fail to understand is the medical bill is what eventually goes to the patient without any notion that we have inherited all the cost where other industries have put onto us. I'm talking about medical device, medication, nursing salary, maintenance of building, all that cost. It is inherited by us and it goes into the patient's bill. So we need to understand the entire ecosystem, the cost of the entire ecosystem, and not just entirely blaming on the bill that you actually present to the patient. And then we end up with a notion that we are actually profiteering, which we are not.
Okay. Now, the cost that you're saying you have now to that you're inherited with, that you have to absorb now, it's part of the medical cost inflation, right? And we've recorded a 12.6% inflation recently. What do you think are the key drivers or towards these hikes?
So 2.6% in our view is actually not a correct figure because it is calculated in a manner that it encompasses everything else that is new into the Malaysian healthcare market. So we are introducing robotics, we're introducing innovative medication and many things that we are innovating, using newer technologies which come with a price. That actually pushes it to 12.6%. The actual inflation is the same like any other ASEAN countries, about 5 to 6%.
Right.
Having said that, out of the 12.6%, 6% of it, our studies have shown we are actually absorbing it. We don't really send that amount to the patient. Insurance says that their premiums are going to go to 40 to 70%, but none of our bills have gone 40 to 70% high in the last 5 years. So there is a disjoint, but of course we cannot relate it in that manner. The insurer may have their calculation, which may be very different. But what I'm trying to say is, in order for us to progress, it is quite inevitable that this inflation is going to be there. Number two, Malaysia has always kept the healthcare cost very low. And that I'm not sure whether that was a good thing or that was a wrong thing. We have kept it very low, trying to be sustainable, trying to make it affordable to our people. And now suddenly we cannot find it sustainable anymore. Hence, suddenly the figure has gone up. So there are a lot of variation, and we really need to not say this in silos. We have to actually sit together with every different party, stakeholder involved in healthcare costs so that we understand each other, and that understanding each other hasn't occurred yet.
Right. Now, speaking of this collaboration between multiple stakeholders and agencies, I want to talk about what BNM has said in the past. So in July, they released a 52-page document on the implementation of co-payment requirements. So this co-payment option isn't anything new, actually. And from what they observed, they said a number of significant developments are impacting the MHIT business, MHIT meaning medical health insurance and takaful, such as the rise in non-communicable diseases, growth of private healthcare services, and escalating medical inflation. So this has contributed towards an increase in the utilization of medical services and magnitude of claims over the years. So I think there seems to be an underlying issue here. Non-communicable diseases. It's highly preventable, yet on the rise. So who should we hold accountable here?
So if you look in the Western world, they are very concerned about getting into a hospital because it is not as easy as how you see in an Asian country. So if you go to any Western world that you want to get into a hospital to get yourself treated, it probably could be a challenge. So in Malaysia, the awareness of controlling non-communicable diseases like diabetes, hypertension, the knowledge and the fear of getting into a complication is still not there. Patients take it very lightly, thinking that there will always be a doctor who can see me. I will cross the bridge when the time comes. I'm feeling very well right now. Where they don't see the consequences when they have an event, that's where the consequences will hit them. You go to a public setting, there's a long waiting list, and you go to a private setting, you have to pay. So I think we need to do a lot more to educate our people that, don't get sick. It is not something that is going to be very easy if you're going to fall sick. I think that narrative has to be louder. And if you don't do that, everyone takes it for granted.
Right. So don't get sick, and especially don't get sick with diseases that are preventable.
Exactly.
Now, back on the insurance premium. So yes, it's inevitable. We have to face the inflation. That there is a rise in prices. So what does APHM then consider a reasonable increase in the insurance premiums in healthcare?
Okay, it's very difficult for us to comment on the way the insurer would have calculated. Then again, I go back to the same point that I made earlier. It is sitting together to discuss. We need to also understand how they have come up with that figure. And definitely they have reasons why that figure was actually mooted. And they may say that it is because private healthcare is expensive. And we have our figures to show why it is expensive. So everyone has a story. Now we need to put it together, and we need to be realistic about it. We cannot just hide away from it, pretend that it is not an issue, and then come and put out controls to all parties and thinking that the issue will be settled.
Yeah.
Sadly, it will not be settled. The reality will remain that the healthcare cost is going to be high, and patients will still get denied the entire care that they need to get. So that's the reality that we need to face. We cannot have a short-term measure just to stop what we think it's going to be effective. So I think we need to be very serious about this and not making a decision that without a real insight into the problem. This is healthcare. We're not talking about something that we can, revert it just in case we have made a mistake in our decision.
Okay. And on the part of the patients, the consumers, what more can they do on their part, really? I mean, apart from obviously not getting sick in the first place, what more can they do to be more equipped with knowledge, with the know-how in, when they're confronted with medical situations like this? Again, the cost is a big issue, but what else can the patient do?
I think in today's technology, in today's world, it is not very difficult to access information. The information is actually in their hands. They do access all sort of other information very, very readily. And I think healthcare is not too difficult because we have chat GPTs, we got the Googles, we got everything that they can actually get this information. Even when they go to a private hospitals do tell them exactly the estimates of what the treatment cost would be.
Right.
And come next year, the government has also made us be transparent on our drug prices. We have always been transparent, but now we will make it transparent electronically or whichever way, and patients are able to see the cost and they will make that decision whether they would want to pursue treatment in a particular hospital based on the cost estimates given by the hospital. So it has been there. It is just that sometimes it gets politicized in the wrong way, and then it gives the wrong kind of what people would say, the wrong vibes. Actually, it's not true. It is not true that we have been very transparent. And one of the most transparent industry in Malaysia is actually healthcare. We can even tell you what the cost of a gauze had cost a patient in a very detailed itemized bill when you go to a hospital.
Right.
And sometimes that is picked up, and then there is an argument, and how come your particular item is so expensive? The idea is not for you to pick up on each time, because that is how the model works, because there is no hospital charge in Malaysia. The hospital will have to make some amount of margins from some of this procedure, and at the end of the day, it is the final price of the procedure that the patient needs to agree upon. So I must say that if you go to a restaurant or you go to a hotel, no one is going to tell you in your nasi goreng how much was the cost of the onion, how much was the cost of the oil they put into it, and how much was the rice. No one does that, but in healthcare we are doing it. And how much transparent can we get? And then transparency sometimes bites us back, as I mentioned to you earlier.
Right. Would you, I mean, speaking still on the part of the consumer, would you recommend more so that the consumers, the patients, get second opinions, third opinions, that sort of thing before they even decide which treatments to go for, which hospitals they want to get the treatment from?
Yeah, of course. Even we doctors will actually tell patients that this is my opinion, this is my diagnosis, and this is the option of treatment that I can give you. And then the hospital will tell you this is the cost. They are they are free to go to any other hospital and make comparison. And some situation, in fact, the doctor will tell, please go and get a second opinion on this, because we do not want to be in a situation whereby the patient may tell the doctor that you told me this, but actually there are others do it better. So most reputable doctors, reputable hospitals will actually give options. Sometimes they may even recommend And you can even go to a public hospital to get your views. Yeah, it's going to cost you much cheaper if you can't afford it. And it is perfectly fine. Our public hospitals in Malaysia have got high standards. And just that you have to wait for a while because they have to serve a lot of people. But their standard of care in a public hospital is very good. In fact, it is as good as what a private hospital can give. But everybody wants the comfort. Everybody wants to choose their doctor. Everybody wants to have the way they want to get healthcare treated. And of course, there's going to be a cost to it. So I personally tell my patients that if you want, you go to a government hospital, they are good. The equipment in a government hospital and private hospital is the same, of the same standard.
Right. And I'm asking this because, essentially it comes down to choice. And as far as I can tell, and as far as we can see, we live in a free country, free market where people have agency and choice, right? So in Parliament, when it was raised by an MP about there's it's necessary for the government to intervene. The BNM should look into this because the MP said that it's not a matter of free will, or that's a willing payer, willing buyer sort of thing. That we're talking about healthcare, but again, like what you've just explained, we understand that people do have the choice. So how can we put the message out there about making the right choices, not necessarily saying the government or regulators should have their hands off, but making sure that people can make the right choices and knowing that they have agency.
Yeah, so patients come to a private setting at their own will, at their own choice, that they have decided to take a medical insurance and they would want to seek private healthcare. The choice here is been made by them. Now, the reason why they make the choice, that is their choice. Now, we cannot simply say because they have made the choice, now the private healthcare has to make it suitable for them, accessible for them at a cost which it is palatable to them. So now that becomes a problem because we have a cost. The insurer also have a cost. Everybody has a cost that we have to sustain. And I mentioned to you earlier, we don't make that kind of profits like how it has always been portrayed. But the choice is made by the patient.
Right.
And there is no way at no time that they will not be treated in a government facility. But why the government facilities may not be conducive to them, that is something that the private hospitals are not able to answer that because we are running our own business. So the choices are there. And how certainly we will have to inherit that problem and then we have to make it sustainable. So that's a question that we find it very difficult to answer. Having said that, I must say that there are enough of patients that are coming to the private hospitals. Of course, they have the means to pay, they have the affordability, they don't have any issues paying the bill. There are going to be this group of patients who have decided to come to private and they are not able to sustain the cost. That's where the issue is. I'll give you another example. Medical tourists flock to Malaysia now. We've increased medical tourists leaps and bounds, beginning to have more than our neighboring countries, only for one reason, because the medical tourists can give you the testimony that we're giving high-grade medical treatment at a very low cost. And we don't need to do an extensive study, and that this part of it is always disregarded.
Right.
That why are Indonesians coming to our country and they sometimes kind of laugh at us and say that why you guys are saying it's expensive? Haven't you gone to other countries to get treatment? And the level of care that we're giving, it is ridiculously too low. That is what they tell us.
Okay. All right.
So that's the sad thing. That is
Yeah.
the sad thing. And honestly, I'll be very honest with you here. Our private hospitals are full. We are full with patients who can afford to pay, and we have got medical tourists who are sitting at our doorstep, and there are times we are not able to give them a bed because we are full.
Okay. So now you want to have an active role in the discussions and making sure that healthcare is affordable. So what do you think of the potential partnerships between, the private and public hospitals. Uh, what sort of partnerships are you looking, to have? In what in
So
and in sort of what in what on what scale as well? Yeah.
So right now, public and private partnership through Protect Health is ongoing, whereby we do take patients from the public sector, not directly, but referred by the government doctors to a private hospital to do their treatment. They are on an agreed price, something like a DRG concept, which, as I said, it is a workable because government is funding it. It has to be an agreed amount. You just cannot have no ceiling to it, and we are perfectly fine with that. And we have done substantially well helping government patients. IHH, as an example, give free radiotherapy treatment to government patients for cancer, which amounts to millions of ringgit. It's free. It's free. So provided it comes through the government's recommendation. So if there is no slot for radiotherapy in government, then the oncologist would be able to refer to an IHH hospital to give free radiotherapy. And this is often goes unrecognized. This is not normally picked. What is picked is all the other things which are not substantiated in a correct manner. So patients get free treatment, and this program is ongoing. We don't even say that we want to charge you a fee. We say it's free because we know cancer treatment is going to be very expensive. This is only an example. There are going to be a lot of other examples at private hospitals, but it never goes into the limelight. That is the unfortunate part of it most of the time.
Right. Do you think that if we reduce the costs too much, that this will then eventually affect the quality of healthcare provided by private hospitals?
There is a possibility because today Malaysians enjoy getting treatment within the country. Yeah, putting the fact aside that there are some who can't afford it, but the ones who can afford it. And then, as I told you, we have a partnership with the government, and we can actually help our Malaysians. Now, if there are going to be controls, and the worst part, if it's controlled, is legislated. And once the controls are legislated, it becomes very difficult to make any changes. And we are going to see this happening in the next couple of years. That when the technology goes to a level, we may not be able to adapt certain technology to give the best to our patient. We're talking about robotics, innovative therapy, immunotherapy, biologics, using artificial intelligence. All this comes with a particular cost, and we may not be able to do it. And when we are not able to do it, then we're going to have Malaysians going to other countries looking for options that cannot be found in Malaysia. And that's going to be even more expensive, and then we are going to lose medical tourists. So all this has never been thought in depth. And if you do a knee-jerk response to an issue and without detailed insights of the entire pathway and what we're looking for the future, then I think it is very worrying. So that's the reason we have asked that let's have everyone to sit together on one table and do not have this silo views, but putting it together scientifically, evidently, having people who have worked in the private sector, because we normally get views who have only worked in the public sector. They have got no idea about how a private healthcare sector is run. So we want to approach this in a very holistic manner. And it is only for our people, so that our people will then benefit.
Right. And just briefly, I want to go back to you brought up, a good point there. You're saying that hospitals are at capacity. You don't even have enough beds sometimes for patients who come in. So that's a good indication that people still choose, private healthcare over public healthcare. Now, I feel that there's a burning question there for me to ask. Is it then incumbent on the government now to fix this? Because we should be able, the government should be able to provide public healthcare at the highest quality. So rather than hoping and depending on private healthcare to sort of compensate that, shouldn't it befall on the government to step up and make sure that the healthcare that they provide is equally as just as good, or perhaps even better?
Well, I wouldn't want to put this in that manner. I think the
Right.
government, we should know this better in the
Mm-hmm.
sense that they have a duty to serve the public at large.
Right.
And they have asked for an increased budget. And even that increased budget sometimes seems to be not enough. I think they are getting about a tune of 45 billion, if I'm not mistaken.
Mm-hmm.
And it keeps increasing. But I think it is reformation of the public healthcare, which is actually more essential than
Uh-huh.
trying to reform private healthcare. Private healthcare, how much you are going to reform, you are not going to serve the B40s. See, right now with the current move, you are only benefiting some of the M40s and the T20s,
Yep.
and by capping and reducing and controlling private healthcare. But what happens to the B40s right now as we speak? They're waiting for their treatment.
That's right.
Are these B40s been addressed? So I think this question we can't answer because we are in the private sector. We have got no control in the public sector. I think the parliamentarians, the think tanks should actually dive into that more than looking at the private healthcare. If their delivery system is good, then we will not have this issue. I mean, I'm
Mm-hmm.
just putting in a very simplistic way,
Yep.
but as I said very clearly that I'm not in a position to comment on this in more depth because I have no knowledge about how public healthcare needs to be reformed.
Okay. But there is a need, definitely, right, for reforms.
I mean, if you look it in an objective way, it seems to be. But as I said, I will refrain from making comments because just like I don't work in public healthcare system,
Yeah.
I shouldn't be commenting because I don't understand how it works there. Similarly, if you are in the public healthcare system, you need to understand how private healthcare works before you try to make changes. So it's in both ways. So we need to sit together, learn from each other, and definitely we can make Malaysia a better place for our citizens. We are already making it a better place for the foreigners to receive treatment. Why not we do it better for our own people?
All right. Well, that's really great. Thank you so much, Datuk, for all your wonderful and very informative insights into this matter. And thank you again for making time for us on Beyond the Headlines.
Thank you.
Now, Dr. Steven, what do you make of what Dr. Kuljit had to say about the public narrative on the profits that private hospitals make? He said the private hospitals make about a 10% profit after tax. And out of that 10%, 80% actually goes to reinvestments. Is the case now 10%? Is it still too much? Or are we not being fair to the private sector in this regard?
I think to that question, I must say I'm not able to comment whether it's too much or too little. Okay, you did bring up the question of whether healthcare costs has gone up significantly to the extent that you're talking about medical inflation causing medical bankruptcy. Okay, now let's be on the same page. Healthcare costs in Malaysia has definitely gone up. Okay, there's no argument on that. You ask why is this happening? See? Now you must always remember the population of Malaysia has grown as well. So just the overall cost will go up. What is expected from patients will go up. The kind of treatment, the sophistication of treatment also has gone up.
Right.
Okay, medical litigation costs have gone up. Indemnity costs have gone up. So like every other thing, there will be an increase in costs. Is this reasonable? Not reasonable. It's obviously quite clear that we are not looking at it in a more, say, analytical way. Things get very emotional. Okay? Yeah. On a day like this is a hot potato.
Yeah.
Okay? Now, you ask, are more people getting sick? No, just the population has increased. Definitely more people will get sick. Okay? Now, comprehensive coordinated reform to contain healthcare costs will be critical. That's what the claim has to be. See? But what is this comprehensive coordinated reform? At one time, the word was reform.
Right.
the Malay version is reformasi. Then the word became a taboo, isn't it?
Yeah.
Then the word was changed to transformation. Okay? So we have this various change of terms and hype. Okay? But end of the day, there need to be progress. Okay? To deliver good quality care to the patients. Okay? You've asked, is there an elephant in the room? I've been watching this for more than 40 years. I work in a private sector hospital, watching change occurring, watching the interaction between patients and doctors, doctors and insurers, private hospital and insurers. And I can tell you, the elephant is too big. There's no more room. Okay? Where is the elephant? Who is the elephant? The elephant is the business of medicine. For decades, we have said the business of medicine is not regulated. It's under-regulated. There are no effective regulations for the business of medicine. Okay? And in which case, then you look at the business of medicine. Private hospitals, for instance, okay, they are in the business of medicine. They are not there for charity. But who owns the majority of private hospitals? Have we asked ourselves? The government is the regulator. Can the regulator be a part of the business?
Right.
When you talk about this, then you see, hey, where's the elephant? How come after 40 years things have not changed and all of a sudden there's this big hoo-ha about insurance costs going up, private hospital bills too high? I mean, something is obviously happening. Maybe the time is right for the national health finance, national health insurance, but this all must be discussed openly in total. And the people to consult is not just the doctors, the hospitals, the insurers. How about the public?
Right.
Have the public been informed? Have the public been opinioned about this? Is there a survey to say what the public wants? Everyone thinks DRG is the silver bullet. It's not, no. DRG is old story. Many countries have adopted it and has given this up. And many countries have found that this is not the silver bullet that they think about.
Right.
You can't contain healthcare costs in the long term with DRG. It comes anyway. So obviously there is business to be made, there's profit to be made. That's why these companies are here.
Right.
Okay? So end of the day, I say, all right, to even consider full fee-paying patients in a public hospital is also going to be retrospective. This is supposed to address the brain drain. The story of brain drain is not new. No? This is since the 70s. And we are still talking about addressing brain drain, trying to insensitize doctors, trying to overproduce doctors. Obviously something is wrong.
Right.
I think so-called the need for comprehensive study, coordinated reform is one thing. Over the years, we have seen various studies. We talk about white paper, now it's paperless. Okay? All right. Maybe it's time for a royal commission. This matter cannot be examined internally, It got to be independently.
Right.
Okay? And perhaps the royal commission can give you the answers that we are seeking. So a lot of these so-called stopgap measures eventually fail. We have gone through all this before. So the healthcare of this country has got three legs, the stool. One is public health. Okay? The other is curative health in hospital base. And the third is primary care. The GPs, the government outpatient clinics. And each and every one of these three legs is under stress.
Right.
The primary care, the GP leg is also under stress. One of these days, that leg will break. And when the leg breaks, the whole system collapses and costs will just shoot up. Can you imagine a failing GP system and with everyone then going to hospitals?
Right.
Yeah? So we have been asking for at least a good look, okay, a comprehensive look involving all parties.
Right.
Okay? And I think time and again they say the Royal Commission is the answer. Yeah.
Would you say, is it fair for me to say that at this point, from what you've told me, there's a big issue with being understaffed? I mean, across the board, we just don't have enough manpower to ensure the smooth running of the healthcare system.
Cannot be true. We have produced so many doctors over the years. We have produced so many nurses. You see, it's just a question of how they distribute and they manage this manpower. In some, you are supposed to have more than our doctor to population ratio is supposed to be better than what WHO recommends. That's how we had so many medical schools. But we are still talking about brain drain, shortage of expertise in remote areas. So it's clearly a distribution issue. Now, you got two sectors handling healthcare, the public sector and the private sector. Most studies have looked at both sectors clearly tells us in the public sector, it's wastage. There's a lot of wastage. Okay. In the private sector, the issue is over-servicing. Okay. Now, DRG cannot handle what's issue in the public sector.
Public setting, okay.
So anyone dreaming that DRG is the answer for the overall situation, no, it's not going to be so. Perhaps it can address the over-servicing for a short period of time in the private sector. But eventually some other system has to come in. Well, they say, what's the best? Why look at different countries? You say the best everyone acknowledges is in Switzerland. They're supposed to be the best healthcare in the world. Yeah, their system, you're talking about paying taxes up to 40% of your income for healthcare. Okay? For a start, just for healthcare. But are we able to afford this our tax structure? Okay? We had a very good system. Okay? Where in the world can a sick walk into a GP clinic at this moment, get treated, get the medicines in a one-stop situation, and then be back to work in an hour's time? Where in the world? Nowhere. At a price that is impossible to imagine, even in Southeast Asia. Okay? They can likewise do so for a specialist clinic. That's where this question of over-servicing comes in. So you're going to put a gate. Before you go to a specialist, you got to see the GP. So that's going to create a queue. Okay? Insurers come in. When insurers come in, they cherry pick.
Right.
They are not going to insure someone who is 65 or someone who's got bad family history of diabetes at the same rate. All this cherry picking will occur and eventually will come in even when there's DRG in private hospitals. I've always asked, is it that difficult to control costs in private hospitals? Because by and large, a lot of private hospitals are owned by GLCs. And who own GLC? The very name tells us. Boss is there, isn't it? Yeah. Is it that difficult? Do we need to overhaul the system to create this sort of change?
No.
Okay. Oh, that's why I say it becomes a hot potato. And you ask me, where's the elephant in the room?
But I suppose
The
at
elephant
least
is so big I can't see the room.
I suppose at least the government now with the Parliamentary Select Committee, right? They're making the first step at least.
Yeah, that's correct.
Making the 6
That's
recommendations.
Okay, yes, sorry.
But like
That
you
is
said,
important.
you want to get more stakeholders involved, i.e. the public.
The public must be there.
Yeah.
I think a national survey must be done. How can we move forward like this?
Yeah.
Who eventually pays the bill? The taxpayer. Why they ask doctors for? It's the taxpayer that pays the bill. They must be there. Say, hey, we want this system, or we want the old system in a modified form. You see, that's my feeling. And this is we have been officially saying this is probably the right way because we have been in the delivery of healthcare at the very level, sitting there with the patient. You see, the original concept of the doctor-patient is a social contract.
Right.
It's a social contract. Yeah. Now you are imposing a commercial version into this contract. it's going to create a lot of difficulties, both for the patient as well as for the doctors. Okay, we have gone to situations where exclusion clauses made it impossible for patients even to seek treatment. Okay, for even getting a guarantee letter takes so long that they just give up. Okay, and complaints from the payers, complaints from the doctors, the private hospitals themselves. That means something is not quite right. Okay. Okay. Before we talk about just addressing it with a payment mechanism, I think the total relook at the system is required. It's not that it has not been done; it has been done in the past. Okay. I think all those expertise, all those experts in the past should be brought back to relook at the system and give advice to the government.
Okay. Now, on making healthcare more comprehensive and private healthcare that, with the co-payment option now on the table, again part of the cost distribution and cutting measures, what steps are in place to prevent co-payment options from deterring individuals from seeking necessary medical care? Because you've already spoken about how there is this cherry picking by the insurance companies because, of course, they want to prioritize profit over anything else, right? So how do we make sure that everyone still can get a chance for decent treatment?
Co-payment in a limited way is of some value because it helps you change the user behavior. Very often when someone comes to see a doctor and they carries along a GL, a guarantee letter, they will want everything in the GL. They feel that they're entitled to everything, be it related or not related. Okay? All right. So, to a certain extent, the user must be made to understand their responsibility. Okay. But what level of co-payment is correct? What level is suitable for the bulk of people buying insurance? I think this has got to be looked at separately. You cannot just say, oh, we have a co-payment. Okay, we hike up the price, we have a co-payment. On what basis? Don't forget, all these insurance companies have been through this journey. They have been through healthcare reform, they have been through healthcare regulations, they have been to DRGs, and they're moving on to other models. They have done this in other countries. They are now here in Malaysia.
Right.
They are here in Malaysia not to give you charity or... Okay. Why are they here?
To make money.
Their business, okay. The day will come when they have done their deals, they will leave. And who is going to carry the baby?
Right.
You and I, the taxpayer, will carry it. So before we step into that realm, I think let's relook at our system. Our system is not bad, I personally don't think our system is bad. Ask anyone who has come back from London or from UK or Australia, say, hey, not bad. We guys here can see a doctor quite easily. Nominal cost to them. You're not going to wait 2-3 months to see a specialist.
Right.
In UK, you may have to wait 2 weeks to see a GP, to get a GP appointment.
That's right, yep.
All you get is a phone call. So how bad is our system? Before if it's wrong, then let's fix it, okay? All right. You think the insurers, how do they get into themselves into squandary? For a company to get critical mass, they must sell cheap, they must buy cheap.
Right.
And when they cannot handle the real cost, then they start asking for increase in premium. This is my look at it. This is how we sitting here. There's an actual cost to it.
Yep.
But what's the comparator? You say private healthcare cost is very high. What are you comparing it? Public? Public is virtually zero. $1 compared to zero is already 100% already, 100 times more. See?
Yep.
So, in a certain way, I can say the cost in private sector has got its calculation. It cannot be the same as in public sector.
Right.
Okay? Whether they say exorbitant, not exorbitant, subject to audit. So you ask me how many percent they make, I don't know. I don't own the hospital.
Okay.
I don't even go near to their accounts.
Right.
Okay?
Now, because this relates directly to like you mentioned, how we compare the costs to what are we comparing the costs to, the private hospitals, right? So we are obviously looking at public hospitals, public healthcare. Is it not enough with what the government has been able to do or has spent? Because it feels like that's the case. And you brought up the case about Malaysia actually being an attractive health tourism destination. So it feels like it's a bit of a contra between like how the Malaysian public feels what the healthcare industry is like here, as opposed to the tourists who come over here for our cheap healthcare. So is there an underlying issue of that means that the public healthcare needs to buck up? Earlier, Dr. Kuljit also touched on reforms, not for the private sector, but more for the public healthcare. And in this case, from hearing what you just said, there is a gap somehow, and it needs to be addressed. Between the public sector having to maybe do a lot of the heavy lifting, because perhaps the public healthcare industry or the public healthcare cannot provide what is necessary to serve the public. So, in this sense, then, how much more does the government need to spend to improve public healthcare so that it can get to a level where it's good enough?
No, I think public healthcare provides, for the majority of those who are not able to afford.
Right.
Okay, which is good. Okay, this is our DNA, our healthcare we inherited. Was a social system.
Yeah.
Okay, all right. And the private sector has growth in tandem. Maybe even beyond what we expected. To the extent that we find, if we are cheaper here than say other countries, then something is either wrong with our pricing.
Right.
And then we start saying, why are we spending this sort of money to treat patients from other countries where we don't have enough for ourselves? So you say we don't grow enough paddy, how can we sell? We must grow enough for ourselves. So I say the three legs. Okay, the primary care leg has been twisted. Okay, is the public care leg been twisted or not? Only the government can twist that out. The rakyat can twist it. Okay. Private hospital, then the government can twist it. Okay, the buyer can twist it. Okay, but then who owns it? Who owns that leg?
Right.
All right. So therein lies a very difficult equilibrium, which cannot be just solved by stopgap measures. It has to be very comprehensive.
Okay. Now back to the issue about monitoring back to the whole issue here. You're here because we want to talk about the measures addressing the rising cost. So, what role will continuous monitoring play in addressing the price volatility for essential medical services?
I think first the rakyat must breathe down the neck of the right people.
Okay.
Be it in parliament or whatever they must. Now, to improve sort of monitoring, we ask, what's the oversight mechanism? I can tell you in a private hospital, what's the oversight mechanism? You look at the law. The law allows for or provides for a medical and dental advisory committee.
Right.
To represent the doctors practicing in the hospital. Okay? All right? The law requires that this committee represents the doctors practicing in the hospital. Now, for us, what's good enough? Say represent means is voted in. Voted in. Actually, the MDAC is a very powerful body. Okay? They are the eyes and ears. Okay? For feedback to the ministry. It should be direct feedback. Okay, all right. But over the years, you find a lot of MDACs are no longer elected. Okay, they are semi-appointed. Okay, so they are in no position to tell the ministry, hey, this is going wrong in this hospital. Okay, this has been done before. Some members who have reported to the ministry, they themselves get sacked from the hospital. Okay. Now there is absence of an oversight, that means from private hospital back to the ministry,
Right.
who is a regulator. Okay, and I believe all MDACs must be elected and be independent to advise. They have to advise the board of management on all medical matters, all, including fees. The MDAC cannot say, I cannot advise you including fees. I can advise you including fees. Okay. So for that particular reason, I think the ministry will have to relook at that. The powers of the MDAC, and then where are they going to get feedback from? Otherwise, they wouldn't have anything. So I'm talking about private hospitals. Okay. There's also a need for patients or medical ombudsman. Something goes wrong, there must be an ombudsman. Okay?
Yeah.
We have called for this for more than 10 years. Okay. And down at the GP levels, okay, GPs must be empowered, okay, to provide health awareness, preventive health at a cost. You don't allow them patient to fall sick, then you treat. That is, not cost productive, okay. Patient level, there should be patient advisory councils, okay, and at the level of subsequently, when things go wrong, okay, there must be statutory requirement for mediation before litigation. Otherwise, all this medical litigation cost is going to go sky high.
Yep.
And it's going to boomerang back to the practice of medicine. It's going to boomerang back to the cost in the hospitals. See? So it's not something, all these measures must be in place before you even talk about costs in the private hospital,
Right.
the DRG. Where are all these things? These are not there. You know? So, still got a lot of work to do.
Okay. Is there any truth, do you think, to the statement that perhaps with preventative, because you're talking about this comprehensive approach, right, to make sure that everyone gets the treatment they deserve, and also to prevent from the healthcare industry being overburdened in many ways, I guess, what we're seeing today. So is there any truth to the statement that maybe preventative medicine or preventative measures in that sense is not as profitable as, say, treatment to then cure the disease? And this is the problem. It's this this mindset that the healthcare industry has, which then bleeds into the obviously insurance companies who would want to maximize profits.
Actually, there should be incentive to remain healthy. Okay, and there should be incentive for programs, okay, to keep patients healthy. Okay, long before they fall sick. Okay, and what does this come on? There at one time there was definitely insurance programs they were talking about. If you can monitor a patient's weight, his BMI, sugars, and keep it down to a certain level, you get a certain incentive. Okay, these are good things, And it should be pursued more than just talking about money at the other end. Okay? But these are not there. We did try to implement one of these, but somewhere down the line, the insurer disappeared. Yeah.
Okay.
Now, even the very question of wellness, how much money is spent every year on things that doesn't matter? Supplements,
Okay.
right? Of alternative medicines of various forms, all right? Okay. Gadgets. The public spends a lot of money, man. Perhaps maybe even more than the curative health, all right? But there are no regulations. So just buy what you think it keeps you healthy. I've seen people buying also machines, that shake them all over. They're thinking
Right.
that will give them a good cardiovascular return.
Are you talking about the smartwatches and the smartphones or the
Those
apps?
are monitoring devices.
That's fine.
They are monitoring devices, all right. But come a day, you need to monitor your sugar 24 hours, your pulse rate 24 hours. I think you're in serious trouble.
Okay.
Most of the time, you and I walk around with that. We're having to look at that.
Right, right.
Okay? Like in everything, anything in excess is no good. Okay?
Right. Now, Doctor, we have maybe 5 to 10 minutes left,
Sure.
I was just told. So just to wrap up the discussion, can we kind of go back to, the main points of, so the government has taken this step. They are proactive in the sense that there's a parliamentary select committee now handling this, or at least trying to solve the problem. So what's the most immediate thing that needs to happen now, following what the government has already done?
Regulate the business of medicine.
Okay.
The managed care bill or act is long overdue. Okay. There are other healthcare acts which are not even enforced or enacted. For instance, the Private Pathologist Laboratory Act, 2010. Today is 2024. No regulations.
Right.
Okay. So all this have to be there. The business of medicine must be regulated. The practice of medicine is over-regulated. Right? Don't put any more regulations. Otherwise, your primary care leg is going to fracture.
Okay.
Okay? And at that stage, the three stools will just collapse. The business of medicine must be regulated. What's there to regulate the managed care organizations now? No. They are owned by companies which are not under Bank Negara. Some of these companies are called employees benefits companies.
Right.
I mean, corporates like to go for these companies because it takes away all the headache of managing their healthcare budget. See? But don't forget they are there as a middleman. They will make their due share, no? Okay? The patients are not going to get their $1 worth. For every dollar they pay, they're not going to get a $1 worth.
Yeah.
Okay. Let's face it now, it's there. We have talked about it, but we have asked the Prime Minister, hey, we have sent you an open letter. Regulate these companies. Something is not right.
Right.
And this is something we have been doing for 20 over years, since 1998. Regulate. Yeah. It's a long time, 1998 to now. Okay. I once wrote a story, The Death of a Good Doctor, Dr. Good. That means the clinic from being a fully fledged clinic suddenly shriveled to death.
Right.
Which is true, the clinic is closed, the clinic, but the doctor's still alive. Barely licking his wounds. So regulate
Right.
the business of medicine before you talk about anything now.
Got it. Regulation.
The business of medicine. It's not different from the practice of medicine, the business of medicine.
Right. Yep.
There's none. Let's accept it like this. It doesn't exist. That's why we hear Bank Negara saying the Ministry of Health says it's the Bank Negara's responsibility.
Right.
It's a bit like dengue, isn't it? When there's a dengue case, a mosquito, this Dewan Bandaraya.
Okay.
They say it's dengue, that's Ministry of Health.
So stop passing the buck.
Yeah.
And time to regulate
You asked me,
business of medicine.
good question, where's the elephant in the room?
Well,
It's,
there you go. Yeah.
It's so big.
Right.
It's so big.
Perhaps there's more than one elephant at this point.
I think it's so big I can only see one.
Well, I think it's best to leave it to our viewers to sort of, make of what you heard, really. Make of the information what you will. Once again, thank you so much, Dr. Steven.
It's my pleasure.
For your very wonderful insights into the matter. That is unfortunately all the time we have for today. I would like to again thank my earlier guest from my video call, Datuk Dr Kuljit Singh, the president of APHM. Well, folks, if you enjoyed watching this episode, please do hit that like button on our YouTube channel, the channel that you're watching this episode on right now, NST Online. And don't forget to also follow us on all the socials. We're on Facebook, Instagram, and X, or Twitter, for all the latest news and updates. Well, that's it for today. Thank you so much for watching Beyond the Headlines. I'm Hazween Hassan, and until the next one, it's goodbye.